Wael, Shokka, and case from yesterday. Will be very brief, inshallah. Dr. Shokka is a senior consultant interventions from Al Qasim Hospital, and I think a case of perforation or something like that.
No, it's
Changed.
no. You asked for stent thrombosis, and
Stent
that's
thrombosis,
why it's a
stent
very
thrombosis.
simple one. So, okay. First of all, I'm really happy to be here with GIS group that I consider them as friends always, and we never miss any GIS meeting. And unfortunately, yesterday it was an urgent. We had an urgent situation, so I couldn't come. After these very complex cases, my case is very simple in comparison because I was asked to present about stent thrombosis. So our case is a 58 years male patient. He is non-insulin dependent diabetic since 6 years. He's an ex-smoker. The patient presented with a non-ST elevation MI acute coronary syndrome with the raised cardiac enzymes and recurrent chest pains and dynamic ECG change, the normal package. He had an echo that showed left ventricular ejection fraction of 40, resting segmental wall motion abnormalities in the LAD territory, and mild MR actually, or trivial MR, and other things are normal. His lab, his troponin I was, high sensitivity troponin I was 90,000, which is a very big number. Otherwise, he was uncontrolled diabetic. And the patient, for the sake of this case, this patient was from the continent, from Bangladesh, and we had some language barriers with him, but there was a translator always available. CAG was done. His RCA was atherosclerotic with no significant stenosis. LAD showed proximal LAD critical stenosis and mid LCX moderate stenosis. So we decided to go, and here other views. The proximal LAD was a very proximal lesion, and before giving two big diagonal branches, and that's why he had this troponin elevation. So I'm fond with imaging. I do most of my cases imaging based, imaging controlled and guided. So a run of OCT was done just to get the MLD, the morphology, length and diameter of the lesion. And upon the MLD, we chose Zion Sierra 3.25 by 23. Before doing any post dilatation, I usually another run of imaging. Next, I don't know why it's not. Next, please.
حركوا يا شباب. Can you move? شو صار بعدين?
I don't know.
No, what happened to the patient? Tell us.
No, we've done OCT. And OCT was, we had a very good result. We calculated the max. There's no edge dissection. The stent expansion was more than 100%. It was 123%, and no no malappositions. So we were very happy about this. And the patient here is the OCT result. And what's nice about imaging that you go home and you know you have a good result. There is no suspicion that this patient, they will call you about any thrombosis or complications. So here we were using, as you see, it was 116% expansion. Minimum diameter was 7.3. Area was 7.3 or 7. It's really good. So we were happy. We kept the patient 48 hours to check his creatinine, and he was discharged on ticagrelor, BID, aspirin, bisoprolol, perindopril, and rosuvastatin. What better can be done? But unfortunately, after 4 days, the patient came to our ER with ST elevation in anterior ribs. It was really unexpected. I didn't see this coming. How can this happen? We asked the patient, he's taking his medications. And we went, balloon dilatation, thrombus aspiration. We knew it was a 3.25. We post-dilated with a 3.5. We wired the diagonals. We actually flow in all the side branches.
So do we know the reason for his stent thrombosis?
I will tell you the reason.
Anyone here? My panelist, anyone to say something? Reason for stent thrombosis?
So this is more than 24 hours. When we see somebody come within 24 hours, this is a technical issues. He showed his OCT before, and the stent is well opposed, but not well expanded. There is a segment in the mid-center. Even though you show the average of 116%, there is a segment in the mid where you're still not fully expanded.
He slept well, he said.
Huh?
He slept well, he went home.
What?
هو كان مرتاح من OCT قصدي. نام مرتاح هو.
ضميره يعني.
Actually, we can go to the OCT. It was, sometimes you accept, with OCT, you see, there was no edge dissection, Dr. Musa. We can go back.
Wael, هو كان في المستشفى?
No, he was discharged. After 4 days from discharge, he came back like this. We asked him, you were taking your medications? Yes, I'm taking my medications.
Okay. Which medication?
But there is a risk factor. I told you what is the risk factor for this patient at the beginning.
Sometimes when you don't have not only a good opposition, but well expanded.
Yes, it was.
It's what I don't know.
No, the max. We calculate the max for the expansion. We calculate the max. Expansion was. You mean this area? I think, Doctor.
What about Plavix resistant? Is he on Plavix or Tika?
He was on ticagrelor.
So that red,
Again, few
that red part.
patient.
Red.
Yes, here.
Look, it's not going to be 100%. You can never get 100% expansion. 80–90% is acceptable. So
Yes, actually,
in most cases, this is what you're going to end up with, and I think this is an acceptable result.
even the Altron, the new OCT from Abbott, it is 90% is acceptable. But anyway, I was thinking about this, why this happened.
Subacute, okay.
I'm doing imaging not to see this always, so. How come, Dr. Musa, we have the stent here?
لا بس شفنا OCT حلو ما نام مرتاح الرجال. يلا وائل.
Okay. So anyway, after I know everybody's tired. So after we took a proper history of the patient, and we got someone because he's a Bangladeshi. It was, and he doesn't speak even Urdu. He doesn't speak Urdu.
خلاص.
So he went to the pharmacy.
عرف السبب.
And he has insurance, and they asked him, okay, your
Plavix.
insurance, there is one. No, he didn't take, he got the aspirin, he got everything, and he didn't get the ticagrelor.
Yes.
And when you ask him, okay, you are taking your medication? Yes, I'm taking my medication.
Which one?
And it was clearly the ticagrelor. He dropped the ticagrelor, he got the, because of the insurance, and you're asking him. I asked him by myself, you are taking your medication, I'm taking my medications. But the nice thing about imaging, that I was sure I had a good result. If I didn't have done imaging, can discuss a lot. We can discuss a lot, maybe you have an edge dissection. That's the message here. That, okay, if you do your cases imaging based, I know everybody is not, can say sometimes I'm overutilizing imaging, but it is for proper optimization. You get better results, you discharge your patient, you know that really he is safe, unless he is Bangladeshi and he doesn't take his medication. Also, I told him by myself. And what was the action plan from this? That I got, all the team, please, when you are telling them, discharging the patient, get the boxes. Get this medication, you don't stop. If you stop, you might die. This patient, he was very lucky because he was discharged with an ejection fraction 45%. But a lot of these patients, actually, we lose them, we don't see them again. So it is very important. It is a very minute thing, but it can cause lives, and we forget about it. Actually, that's what we are doing. We are showing them the boxes.
Yeah.
This one you have to take. You can drop the others if you want, but this one you have to take.
Beautiful case, Wael. I agree with you, and I think, in a place like yourself, Qasim Hospital, you do, mashallah, great job. One thing I think missing is to give the patient 1 year of ticagrelor. Would have been great.
I just have a question. When the pharmacist dispenses his medication, I think a lot of, since you are like a PCI hospital, they should be aware that patients who had stents need to be on DAPT.
Yes.
So he should not have just left him like this, given him the medication and made him go. This is this is an administrative problem and it needs to be solved. And
No, but this patient, because he have a private insurance, he got his medication. I went through this because what we learn from any case is how to avoid this happening again. The patient got it from a private pharmacy. He did not take from our hospital pharmacy. That's why. I was astounded because they're a clinical pharmacist. How come they didn't give him, they know that he had a non-STEMI and they won't give him the ticket.
Okay. Sharif, Musa, quick comment.
Thank you, Wael, for this nice case, and we all know about the great job you do and Al-Qasmi do. But I will have to disagree a little bit with the routine use of imaging in the setting of acute coronary syndrome. I can't find in the literature something in this regard, and I'm sure it gives you a peace of mind when you do OCT even regularly, especially it is readily available. It's on the basis of the outcome, maybe, but I can't see something in the literature, or maybe, and here we all treat insurance patients. It's really very tough to convince the insurance to use OCT or imaging in that setting. So I don't know what's your experience, or do you have a specific guidelines when to use imaging in the setting of acute coronary syndrome, or you think it has to be used as much as possible or whenever it's possible? Because I find it a little bit difficult to use it routinely in ACS patients.
You can't make it a routine because what you said, because insurance we have resistance, but whenever you can use it, I will not think twice to use it. I'm doing a lot of cases, even SC elevation MRIs, using imaging, you get better results. Really, you get better results, especially with STEMI cases, because STEMI, the sizing is a problem. You're not really sure about the sizing. A lot of cases will come later with stent thrombosis because of malapposition, because you undersized the stent. We're doing a paper right now on the use of OCT in STEMI cases, and I hope we can publish
Great.
it
So
soon.
thank you very much, Wael. I mean, we do imaging when we have a stent thrombosis. تفضل موسى. آسف.
Commenting on the stent fracture, I had exactly the case done with imaging, not completely was fine, and he post-dilated. 2 days or 3 days ago, he had a stent thrombosis. Then I did imaging, and it was early morning. I did imaging. Surprisingly, I found acute stent fracture as a cause. And that's one of the rare things, but acute stent fractures was because it's important that in a stent thrombosis, the message, whenever you have stent thrombosis, I think you must do imaging to
yes.
understand the mechanism.
Yes, for sure, Dr.
Thank you,
Musa.
Dr.
I
Awad.
totally agree.
Thank you, Dr. Wael.